So we have a potpourri of testing that obviously have been mentioned throughout the morning. Dr. Campbell mentioned vitamin D and how she looks at vitamin D sufficiency and so on. But what I would like to do is try to deal with the metabolic syndrome patient rather than asking several tests in general, but how do you test and how do you manage a metabolic syndrome patient? And I'll start with Dr. Maulfair.
My philosophy tends to be looking at the patient as a whole, not as a diagnosis or as a potential diagnosis. And at this point in our discussion, most of the things that I do have already been discussed diagnostically. And I also explained to my patient population that the therapeutic programs that I recommend are not designed to improve a test result, but designed to improve their quality of life. And as has already been mentioned, we usually are working with patients who would prefer to spend their hard-earned money on therapy rather than diagnostics. And so I don't have a specific battery of tests that I use for metabolic syndrome and another specific battery of tests for vascular disease and another one for frank diabetes and another one for arthritis. I just use some of the basic things that we all look at to guide the therapeutic program. And then, frankly, I don't request that the patient have a lot of repeat studies to see if the study is improved. And most are appreciative of that. Now, on occasion, I do have those folks like a CPA or like a physician or like an engineer who are data-oriented, and they want to see a repeat study. And the fact that their coronary artery disease symptoms have improved to the point where they're, as in one case, this fellow took 100 nitroglycerin a week just to go from one room to his house to another, and 6 months later, a year later, he's taking 2 or 3 a week. Those folks usually don't care too much if their
fibrinogen's better or whatever.
yeah. Although I've had people say, I want to do another catheterization to see, in spite of the fact that my claudication and my...
Dr. Sica?
Pardon?
I said Dr. Sica now.
I do a fair amount of testing, somewhat geared toward whatever the presenting complaint is or what the family history is, particularly if there's, family history of diabetes or the family history of heart disease. I'm going to do a targeted workup that way. I've actually had many patients comment that they really appreciated how thorough I was with the testing. That when they went to their primary care or their cardiologist, that they really didn't feel like they were getting a full evaluation, and that's really made a huge difference for them. So it's a little different than your experience there, but over the years I've gotten, as Quest and LabCorp do more of the kind of more sophisticated tests that we do, I do fewer and fewer specialty labs, although I'd love to do a blood viscosity on everybody, but then you got to get into like how much out-of-pocket dollars are you going to spend on testing. But fortunately, lots available through labs that are covered under people's insurance now, and there's also a discount lab called Doctor's Choice. There's a couple of them, but that you can get if a patient doesn't have insurance or they have a high deductible. You can actually get the testing at a really reasonable rate. And if you guys want information on that, you can contact me later, and I'll get that for you, because that's made it much more available to do more testing. I think it's a good motivating factor for patients if they see their fibrinogen goes from 450 to 350. Their clotting factors are improving or their CRP is improving. They can see the difference. I think I do a lot of testing, but I tend to only repeat the things that are abnormal.
And how about you, Dr. Hickey?
I'm ridiculous.
Oh no, don't say that.
First of all, examination, waist circumference. It's probably 80% as predictive of the metabolic syndrome as any other test we have. I like to do the chemistries. I like to do fasting glucose, obviously, I always do a fasting insulin level since the Helsinki heart study in '87. I like to do a hemoglobin A1C because as that tends up towards 5.6, you're seeing increased cardiac events. I like to do homocysteine because if all else corrects and that stays high, I worry about methylation and lead. I like to do lipid subclasses. I never rely upon a lipid panel, although I'm getting good enough to be able to predict when the abnormal particle sizes are there. So I do a thorough examination of what the metabolic of surrogate markers for the metabolic syndrome. C-reactive protein is fairly useless, but I do it because it's politically correct. If someone is resistant to my advice or our plan, I'll do interleukin 6, I'll do tumor necrosis factor alpha, I'll do interleukin 18 because that correlates very highly with plaque destabilization. So I use whatever I can in their blood test to convince them.
Dr. Campbell?
Yeah, first of all, I'm a solo practice. I do a cash-only concierge practice, and I've opted out of Medicare. So I'm free to do a lot more things that many of people who don't take insurance. And I've negotiated a discounted rate with Quest for laboratories, and every patient that I see on initial presentation gets a blood panel that includes the CBC, the CMP, the lipids, thyroid panel including antibodies, MTHFR, celiac disease, vitamin D, B12, folate, ferritin, HSC reactive protein, and I do that for a patient cost of about $125. So, and the patients love the data. And they keep a track, and my electronic medical records allows me to print a graph. So we watch, in men I also check testosterone PSA, but we track those numbers over time, so they watch their vitamin D go from 18 to 64, and they love that, and they're so motivated, and every year they come in and they want their vitamin D checked again. And the same is true of all these other markers. So MTHFR has been a huge addition to my practice. I found that, frankly, I've had, I think, 5 non-genetic mutations in my practice since I've been testing. Every patient has at least one of the A1298C or the C677T mutation, and then we use methylfolate accordingly depending on how significant their mutation is. And there was something else that was important about testing. There's no consensus on what metabolic syndrome is. It depends who you pay your dues to, whether you're using waist circumference or insulin. Fasting insulin is another thing that I test. C-reactive protein. I think C-reactive protein is really, really important. And one of the primary things that I see has the most powerful impact on lowering that is sending them to a biologic dentist to have their teeth evaluated, because very, very, I would say universally, everybody that I have with the C-reactive protein I can't get down with my initial measures has a dental source for their inflammation.
Gingivitis is the most common cause of the elevation.
Yeah.
So my question now is, do you approach different male or female patient with metabolic syndrome? And what are your interventions of favor? Dr. Hickey?
No, I don't approach them differently. I think the most controversial issue is hormones, and I tend to favor hormones, bioidentical hormones, of course, but for a lot of reasons. I think now, if you look at some of the data, a third to a fourth of women who go on postmenopausal hormones don't do well, but 2/3 to 3/4 do very well, and I think you have to figure that out. I don't know if there's any test I can do other than viscosity studies of the blood, which would tend to make me. Actually, in the old days, we used to say that Premarin, improved vascular viscosity. I'm not sure that, and in some patients that's true, and I don't know how to decipher that patient. But the only difference, in my opinion, would be the hormone status. One of the problems with what I see in postmenopausal women is that if they're losing bone all the crap in the bone is going into the organs and messing up the enzymes and creating all this havoc. So I do everything I can to preserve bone density.
Thank you. How about yourself?
Just to respond to the question about using, when you use estrogen, first of all, I haven't seen estriol significantly raise, or bioidenticals, if you use a biest or triest, significantly raise blood clotting or cause any clotting disorders or cause cancer. But you can check a patient, and I think any physician who's ordering hormone replacement that's not bioidentical, Premarin or anything like that, and anybody who's ordering birth control pills ought to order a genetic clotting study. How many women have died from blood clots, young women on birth control pills?
If you talk to the hematologist, they will tell you that there is not enough number to treat.
But they ought to screen. We ought to be screening and not
that.
prescribing for those women that have,
Right.
A factor V Leiden or a factor
agree.
2 or whatever. I mean, we ought to be, prudent about prescribing. But that's a whole nother soapbox I'll get off of right now.
We will address that when we get into the women's health. How about yourself, Dr. Maulfair? How do you manage your...
I point out to my women patient population the standard medical abuse that they have received concerning vascular disease, as far as its identification and the prevalence, and the fact that more women die from coronary artery disease than from breast cancer and uterine cancer, and that they have been denied access to the system.
So, but how do you manage your metabolic syndrome patient? Do you put in a metformin?
As far as
in general?
Well, I would agree hormones are an important part, an essential part that you have to evaluate. But otherwise, I wouldn't treat a woman any different than a man.
Okay. Except for the hormones.
Yes.
Yes.
Can I make one more comment? The one differentiation I would make between men and women is that testosterone, there's clear documentation that it both will help control metabolic syndrome as well as reverse cardiovascular disease and peripheral vascular disease. So I studied with a guy from Michael Hansen from Denmark, who was the protege of Hans Mueller.
Mm-hmm.
And
Dr.
he
Mueller.
had studies like the one that John Wilson passed around for us. But what they were using is injectable testosterone in very high doses, and you just watch the leg ulcers disappear. It was pretty dramatic. I've got that monograph somewhere in my files.
Well, he wrote a book about testosterone use for vascular disease in the 1960s when we didn't have any other medication. How about yourself?
Yeah, I think I mentioned earlier the difference in gender in the post-2-hour postprandial blood sugar elevation is more prominent in women where fasting is. Hemoglobin A1C can help you a little bit with that, because if you get her fasting sugar and it's 78, but her A1C is 5.7, then you know it's not her fasting blood sugar that's the problem, it's her postprandial. So I do a lot of 3-hour glucose tolerance tests in the office. I think hormone management is important, and my primary probably treatment intervention for those patients is I have a lifestyle educator in my practice who does first-line therapy. So it's basically a lifestyle program that involves how do you sleep, how do you de-stress, how do you eat, how do we get the carbohydrates out of your diet. It's typically meal replacements using either Metagenics or Zymogen protein shakes, ultraglycemics or optiglycemics. Start with a protein shake in the morning, maybe have us, depending on what your insulin and sugars are, you may be on a 3-meal-a-day or a 5-meal-a-day plan, kind of depends on what your sugars and insulins looks like. And then really work on reducing the carbohydrate, that visual of the Idaho plate method, where you have a 6-inch plate, not a 10-inch platter, but a 6-inch plate. You split it in quarters. 2 of those quarters or a half of the plate is your green vegetables. 1 quarter is your 1 cup starch serving. That's all you get at any one meal is only 1 cup of starch, and then your protein portion. So if you use that simple visual of, a piece of protein, a bit of carb, a bunch of green vegetables, you can really manage very well. And in some people, we get much more accelerated weight loss if we skip the carbohydrate altogether and we use only the carbs that are in the green vegetables.
So basically, you are doing a modified zone diet or modified Mediterranean diet.
Yes, exactly, and relatively high in the healthy oils. Of course, we push fish oils and we push nuts and seeds and avocados and olive oil. I think that those are a very important part of maintaining the mouthfeel of food as well as the satiety index.
So part of the questionnaire included asking the panel in regards to which phytonutrients do you use for memory improvement. We know that there is a direct relationship between metabolic syndrome, type 2 diabetes, and the development of cognitive dysfunction and dementia.
I think the micronutrient you don't use is sugar.
Well, that's a macronutrient that we
you got to
don't
get
use.
rid of that before anything else.